So let's start with the introduction to survival analysis, and there is some disclaimer. The disclaimers just to the content is the presentation is only intended to healthcare professional in India. Medical informations in the presentation is provided as an information resources only and is not used for or relied for any diagnostics or treatment purpose. The view and opinion mentioned in the presentation strictly that the authors and individuals express the same, and Pfizer may not necessarily endorse the same. Pfizer's, including its parent subsidiary and affiliated entities, makes no representation or warranties of any kind expressed or implied as to the content used in the presentation and the accuracy, completeness of this content. It is a non-promotional medically initiated meeting. Pfizer does not recommend the use of the product on unapproved indications and recommend to refer to complete prescription information prior to using any Pfizer, any of the Pfizer product. So let's start. So survival analysis, see here, as we talk about the survival analysis in oncology, especially in oncology research, it's not only this survival analysis only applied in the oncology research, from engineering to other medical research, everywhere this survival analysis applied. But typically when we talk about that oncology area, then we as you know that survival getting benefited in survival because cancer itself is a deadly disease. So so always we are concerned that what kind of treatment, what kind of therapy or administrations of the treatment can be done where persons or patients residual life can be expanded. So that is the main fundamental reasons of any oncological research and persons, because it's a deadly disease. It's not that other kind of disease that are managed by changing the protocol or making the modifications in this treatment management like diabetes or CVD. But here it is a very much important or focused is area that as much as possible expand the residual life of the patients when the person is detected with the malignancy, any kind of malignancy. But thankfully we are having some kind of cancer that is having better survival, and we are not much more worried about that, and some cancers are really concerned about the survival. So in that context the survival analysis works. So survival analysis endpoint can also be referred as a positive event. So as far as the terminology of survival analysis we talk, so positive event means person survived. So that would be considered as an event, as a positive event. So but while you talk about that in case of while you're talking about the data analysis point of view or the statistical applications point of view, unfortunately the methods are derived in such a way that the persons are alive considered as a non-negative event. I'd say non-negative event means it's a 0, and persons die considered as a positive event. So see here there is a little gap on that, or I'd say there is a confusion start with if you talk about the survival analysis. Basically we are not much more looking on that survival of the patients. However, we are interested in the survival of the patients, but we are deriving or calculating everything with the death of these patients. Okay, so how fast or how one treatment is having more death as compared to another treatment. So reversely, we are basically comparing the survival analysis, doing the survival comparison between the patients, but interest is to look on the death or event as positive, and based on that we are trying to make the comparison. So basically survival analysis can be called as a death analysis because we are in fundamentally technologically we are doing this death analysis, but in commonly we call it as a survival analysis. So survival analysis studies can involve estimation of the survival distributions, comparisons of the survival distributions of various treatment, their intervention, elucidations of the factors that influence the survival times. So that I mentioned that basically here we are dealing with these two things while we are talking about the survival analysis. One is the time and another thing the event. So you know my 2 points are here. The one point is basically the event we are concerned. So event is basically that persons died or not. the person died, then it would be called as an event. If the persons are alive, then it would be called as a no event. So event is calling as a positive event. So that is the one part. Second part is that the duration. So how many days or how many months or how many years per persons were event free, means died death free or alive. So that kind of comparisons make sense here. So now I'm talking about that event as a death, but it is not always that event should be considered as a death. Event could be anything, but it should be time dependent. So like progression of the disease, relapse of the disease, uh, some comorbidity appeared during the treatment, all kind of stuff can be considered as an event. But and survival analysis nicely fit on those event analysis as well. Not only that event should be death and alive, that is not. So if you are having other kind of event, that also be possible to work with the survival analysis. But commonly we apply survival analysis. I'm saying commonly we apply survival analysis while the event is a terminal event, that is a death, that's a final event of any person's life. So whatever the discussions we will make, we are going to make it with the considering the death as event, but event could be anything like marriage of a person's or first child of a couple, or any kind of event can be considered. So after marriage, what is the durations of the first child? So that duration as an event for first child. So that can also be considered an event, but here we are going to consider only the event as a death and terminal event of an individual life. One thing that I noticed that before going for this entire presentation, so what that routinely while we work with this survival analysis, that we always face that challenge, that the data entry. And let me have a clear view on that, how should the data should be there. And there is a fundamental thing that the data should look like. And while we are entering the data, that should be look like. It's a simple Excel file I'm going to present here. And you can see that here that first column is given as the ID. So ID of the identifications number of the patients. So it could be any identifications number. It is not that only should be 1, 2, 3, 4. It could be any ID number of your effort centers, patient ID number, CC number, or any number, but that should be the unique number for each individuals, each patients. So that is very mandatory to having the survival analysis. If not only the survival analysis, in other data set also, that is very much fundamental entry that should be there in any data set. So ID should be remain there, and that should be given as a numbers or combinations of the number and string character, as well as number, year, and other parts you can put. So that is the one thing. Now the second column given here is a treatment. So treat column is given. It could be given as a 1, 2. It could be given as a 1, 0. It could be given as a AB. But what about the type of therapy you are giving? That basically for a person. So that kind of therapy's number or name should be given, and try to make it unique as much as possible. Sometimes what happens, sometimes during the data entry, we could put arm A. So capital A, capital A, then R, then M, A. But sometimes we put small a, R, M, A. So that should not be done. So make it unique. Make every person's, those are given arm A, you can put as a arm A, capital A, R, M, A. Don't make a different combinations of that. Like sometimes we put the male and female, sometimes put small m and small capital M, sometimes put M-E-L-E, sometimes put capital M-A-L-E. So all sort of combinations come. So my request is that while you are putting the treatment kind of things or any kind of discrete data variable, so try to make it as unique as possible. So that like makes simple, because ultimately we are going to make the comparison between treatment 1 and treatment 2. So that is the one thing. Now the third thing that I present here, that is column 1 and column C and column D, and these are the very important things. So unfortunately we are having different way of calculating or putting the date values. Sometimes we put DD, MM, YY, YY. Sometimes we put DD, MM, YY. Sometimes we put DD dash, MM, YY. So all sort of combinations are there. Now life becomes quite complicated here, where we keep on changing, because changing this format in one column itself, and column C and column D, because one thing is that we are not going to enter the data at a single time point. So it takes lots and lots of times to enter the data at a single stroke. Nobody is going to enter the data, so it takes lots of time. Simultaneously, different individuals get involved to enter the data on the single Excel file. So what happens, sometimes one is putting the data in one format, another putting in another format. Then problem becomes that while you are going to calculate the survival durations from that data, it becomes quite complicated. Sometimes what happens that like you can see some value like ninth row, so 0201 2020. So sometimes it's becomes quite complicated. Rather than putting it's say that 2nd January 2020, but someone can also confused. Rather than putting 0201, it could consider as a 01 and 02, because some dating standard is also say it's a not 2nd January, it's a 1st February. So there is also standard practice to have that. So, and then life become quite complicated. So during the data analysis, make a simple procedure, and this is the best procedure based way to calculate the data. Enter the date in the Excel file, that is dd-mm-yyy, and always put the standard practice. Once you are having these positions, don't put any extra character in this data, and after that you will get this that duration. So duration is basically D2 minus C2. So just make a column here D2 minus C2 and just drag it, and everywhere you will get by default the durations, and that's a wonderful way. So basically the duration is how you are calculating that durations. We are where the patients comes to hospitals or the registers for a trial, that date is considered as a start date. And while the patients are going to last date of the visit of the hospitals. So last date, that is a very confusing term, and that's why I'm having another topic of the competing risks. But while the patient is having last date of follow-up, then the last date of that follow-up should be mentioned here. If telephonically you know that or can confirm that patient is still alive or patients are died, so those date of death can be also entered here, provided you are having good or confirmations. And sometimes you have seen the death certificate of the patients, and based on that you can say that this is the patient's death. So rather than putting the last date of the visit of the patients, you are having provisions to put that date of the patients. But if the patient is alive but he never visit your hospitals, by telephonically you call them and say that what is that status, and somehow say that he is alive, or alive, the person is alive, that is not a good practice to put that date over there. So unless and until you are confirmed that patient is died, you can put don't put any date, put the last date of the visit of the patients and over here. Otherwise, if you have seen the death certificate of the patients, then you can put the death date. So survival duration should be calculated by subtracting this value minus this value. And now the death value that I mentioned, that if the person died, then person's death is already given here, and correspondingly you can put here death status as a 1. If the person is alive, then you can obviously have to put the patient's death status is 0. So this is these two columns are very much important. Any software, any way you are going to apply or analyze the data, you have to have these two columns, survival and death column, and survival duration and death column are supposed to present like that. Okay, if the person died, then it should be 1, otherwise it should be 0. So now let's say while you are talking about the survival analysis can't be done without any statistical model. Statistical models, there are some existing statistical models like resemble that linear and logistic regression in several ways. There are single outcome variable and mode predictor variable. So basically, while you are talking about the statistical model to apply or survival analysis model to apply, basically we are trying to find out different combination or different types of factors those are influencing the death of the patients in addition to the durations of the survival. So what happened that these factors, like here I have seen that we have seen that that treatment column is given. So treatment can be considered as a factors simultaneously, gender, that age, like other prognostic factor of the patients can be considered as factors, and those factors, how they are influencing their duration of the survival. So that can be interesting point to look, and we can find out, okay, the persons are having more age will die earlier, the persons are having male or female having no difference on the survival, or that kind of recommendations, or the persons are having poor prognostic status, died earlier than better prognostic status. Grade 3 and grade 4 people are dying earlier than grade 1 and grade 2. So all sort of combinations, all sort of recommendations can be obtained by applying the statistical model, and that's a reality to apply that any statistical model. So basically, this statistical model works in the two way. One is the linear or regressions, and the survival analysis model is basically the existence of the combinations of the linear and logistic regressions model, basically. So now once that is the model is done, then our next job is coming to how to make the statistical hypothesis test. So testing statistical hypothesis is about the relationship of the predictor to outcome variable in a particular interest. So that I mentioned, so that while the age, gender, and all these prognostic factors, how they are contributing towards the outcome of interest. So outcome of interest is basically the patient survival duration and their death. So that is the one thing, outcome of interest, and thereafter we are trying to find out. Sometimes what happens that we need to adjust some factors like gender, like different age category, and so that kind of things are sometimes required. So adjustment of the confounding factors, covariates, are also taken place while you are talking about the statistical analysis model over there. So thus it is better to have the basic concept of the classical hypothesis testing and the principle of the regressions analysis. So I hope that we once you attended that earlier presentation, so some basic principles of these hypothesis testings and the regression things are already covered. So that's basically those steps we are going to make it here. So the key characteristics of the survival data analysis is the response variable is a non-negative, discrete, or continuous random variable, and represent the time from well-defined origin or a well-defined event that I already discussed. So now the terminology called I put here one there called censoring. So what is the censoring? Censoring is basically that with the events we say that the death event, death as a given as a 1 and 0, those are given as a 0, those are called as a censor. So censor is not that cinema is having the censorship. No, that censorship is not here. Censoring is called as when the patients are alive. So you don't have that informations, the patient's death informations, or typically censoring. It's why it is called censoring. It's some extent the negative terminology used. Basically, that what are the fundamental theory of survival analysis is presented with that every persons are expected to die in a particular time point. So if you talk about 100 patients data and 100 patients data that I showed that the death column. So for the death column 100 patients data, every person's death column should be given as 1. So every person is supposed to die, and that is a fundamental principle in life. Every person would die, and corresponding to that, their duration of survival would be there. But unfortunately, since we are doing this clinical trial or clinical research, we don't have that amount of time to explore or wait for particular persons to get died or all persons to get died. Because if you talk about 100 persons death, we have to observe 100 persons death, we have to prolong the study durations for a long time. And we don't know, because out of 100 persons, 1 and 2 persons may die after 20 years, 25 years. So we can't complete the study within a couple of months or a couple of years, because that's not having a positions to complete the study, because you have to, for 1 and 2 or 3 persons, we have to wait for certain time points unless and until then. But survival analysis is prepared in such a way, theories like that, but is prepared in such a way that it can handle that kind of scenario as well. So if the person is alive and not been died while you are compiling your study, still it can handle that work. It can give you the inference that how the patients are died, but those persons are alive, those are considered as a censored observation. So that is the lacuna, of the survival analysis to call it, basically. That's all. The second characteristics of survival analysis censoring arises when starting or ending event are not precisely observed. So another way of censoring happen, like we don't know while we are talking about that censoring is a basically what I mentioned, that patient is alive, that is called as a censor. But sometimes censoring also occurred that before the study entry. So what does it mean? That uh, while you are talking about that the starting date and end date, while I mentioned that the starting date is basically we are thinking that this is the date the patient is coming to a trial, and from that day we are talking their baseline observations into the trial. But we don't know what is exact time the patients have started to developing the cancer. Whatever the patients are coming to a trial or hospital, the starting date we are going to consider as a entry date, and all the patients are considered that entry date as equal. But unfortunately they are not equal. Some of them are coming after having 6 months of having disease. Some of them might come after 2 months of the disease. Even some of them come after 1 year of their disease, and they are coming to hospitals or for a trial. So that duration, that is 6 months, 1 year, or 1 month or 2 months, that duration we never observe. It's not in a position. We are not never in a position to understand the why when this disease started to occur. So that before that durations also called censored, and that is called left censoring kind of concept. But that is also called and that is there in that. But somehow we do ignore it because that's limitation of our knowledge, I would say, to capture that information. So most common example of this we talk about here the right censoring, that which result when the final endpoint is known or only known to exist in a particular value. So we overlook that left censoring part in oncology setup. And these are the combinations, basically left censoring and right censoring. These are the combinations of the type 1 and type 2 censoring. So let me explain what is that. Censoring may be classified into 3 types: type 2, type 1, type 2, and random sampling. Type 1 censoring is that when the censoring times are p-specified. For example, in animal experiment, a cohort of animal may start at a specific time and all followed until a pre-specified ending time. Animals which have not experienced the event of interest before the end of the study, that are called the censored at that time. So this is the one example of the type 1 censoring. Animal experiment, we can say. So we started to having the cohort and started to observing a specific time point, and we say that we let's say we are not going to follow an animal or follow an person for more than 3 years. Our stipulated study duration is 3 years. So we are whatever that within 3 years the persons are going to have, we're going to conclude whatever the information. So within 3 years, many of them are not having died, or many of them have not having specific event. Those can be considered as a censor. So I'm just shifting from an initial example. Let's see, while I was talking about the Excel file, while I was talking about that survival duration start to end date. So here I was open to have that to observe the individuals from their study entry, start date or start date to end date. But while here I'm just shifting my objective. No, whatever the patients are coming and going, I'm not going to have that positions. I am going to start my study from the, let's say, from January 2021, and from December 2022, whatever the patients are coming and whatever their observations are going to come, that I am going to take. So beyond to December 2022, whatever is going to happen of the particular patients, I'm going to call them as a censor observation. So that's the fundamental difference to having the study design or look the data in different manner. So that gives us that kind of censoring is called that type 1 censoring. Another way, smoking cessation studies, where we designed the study for each subject until a relapse or 100 days, whichever comes first. Those subjects who didn't relapse within 100 days period were the censored attempt. So similar way, the censoring, type 1 censoring stand here. Let's say for type 2 censoring. Type 2 censoring occurs when the experimental objects are followed until a pre-specified fractions have failed. Such a design is rare in biomedical studies, but may be used in industrial setting where the time to failure of a device is primarily of interest. So, for example, that we started with this 100 bulb, and we want to test that those bulbs, what is the life history of those bulbs. But 100 bulbs life history, every day we run it and check it when the bulb is going to fail, that is not possible. So we are going to make that once we are having 1/4 of the bulbs are getting failed or not working, that duration we are going to say, and based on the quality of warranty, guarantee, all kind of shorts are going to happen. But anyway, so that 25 days, 25 out of 100 bulbs, if you are let's say, and you say going to make the conclusion that the whatever when the first 25 bulb get failed, that duration you are going to document and going to say that this is the median duration of the survival of the existence of the bulb, any bulb you consider for a product. So remaining 75 devices would be censored. In that example, the smallest 25% of the order failure time are observed, and the remainders are the censored. Not only this industrial experiment in medical or oncology, typically in example also, we adopted that kind of study design. While we talk about the sample size calculations for the survival analysis, we say, let's say these are our number of patients, and we started with this number of patients. We are going to end the study while these out of these 400 or 500 patients, 200 or 250 patients are having that death or relapse or progressions. So that sort of stories also happen in oncology. So it is not typically, I would say, we started to applying in this medical or oncology setup as well, this F2 censoring way to calculate the sample size and prefer the study design in that manner. Finally, random sampling. It might be a little confusing, so I'll not go more details about that, but it's the last general category of censoring is this random sampling. Careful attention to the cause of the censoring is essential in order to avoid the biased survival analysis. In biomedical setting, one cause of random sampling is patient dropout. If the patients or dropouts occur truly at random, it is unrelated to the disease process, such as censoring may cause any problem with bias in the analysis. But if patients who are in near death are more likely to drop out than the other patients, serious biasness might occur. Another cause of random sampling is the competing event that we are having one topic now. So in clinical trials, the most common source of random censoring is the administrative reason, which results because of some patients in clinical trial have not been yet died at the time the analysis is carried. So again, so random censoring, it is very difficult to understand that reason for the censoring. So I would say that's the way. And when in a dilemma to understand what is the reason for censoring, then it is better to consider as a random sampling, but it's a combination of the both. I got, I think, one. Okay. So these are the features of having this censoring mechanism: patient 1, patient 2, patient 3, patient 4, patient 5, patient 6. So see here the actual started the date the patients entered in the study, and it is, let's say, from 2000 January 2000. So we are talking about the calendar. So it is sometimes get difficult to chase that you are talking about the calendar year or you are talking about that duration or the, but let's stick on the calendar year. So January 2000 we started a trial, and obviously when you started a trial or study, if single day or first day all patients are not going to come, somebody will come later and will like that. But for example, let's say these first and second patients are joined here and they were followed up to, let's say, up to here, and these persons are died here after in 2008. The first patient 2008 died, but we only considers that, or we end our study in 2007, let's say. So 2000 to 2007, that's a long period. We end here, and that time persons were alive. This person was alive, so we consider this person is censored. But beyond that, after only 1 year later, the person died, but we are not in a position to take, and that is going to be the right censored persons here. Here also, we don't know what happened. No, we started with this patient 2, and here the persons died. So obviously that death status will be documented as a 1 here, but here the death status of the person will be considered as a 0. Similarly, third patient started comes to your study into up to 2000 at 2001, let's say in January, but he was followed up to let's say 2009 itself. But still, even he came late, he was observed up to in a trial was up to 2007. So here also we are going to talk this person is censored, or the death status of the person is basically going to be 0. So persons is censored, then their status is going to be 0. If the person is alive, then also person's death status is going to be 0. Only persons during the study period, if they died, then death status is going to be documented as 1, like these persons, and similarly like this person and this person, because during this 2000 to 2007, these 3 persons death status would be 1, because they died all this up to within 2007. But rest 3 persons, patient 1, patient 3, and patient 4, they are not still they died after 2007, but still we are going to consider them as alive, and as considered to be up to 2007 they will be considered as 0, and that the way it should be considered. So the best way to consider that days duration or study duration with a calendar year, that's a very easy way to have. Now second thing is that the study durations can also be split into 2 parts. One is the accrual period and follow-up period. What happened that while we started to considering a survival study or any oncology study, so it might happen that you plan for that only 2 years as a thesis work, you might consider as a let's say only for 2-year study. Now while you started to first year, you started to started to getting the patients, but you said that persons would be alive, we are going to say, and median duration, all stuff. But what happened that every day you are or only single day you are not going to get all patients. So first month, second month, third month, and all the consecutive months you are going to get few patients. Now what happened? Are you going to, now questions comes, my study is only for 3 years, I have to wind up my study within 3 years because my thesis time. But what I do, because if the patients comes after 2 years, should I consider them or should I not consider them? If I consider them, then what would happen? If I not consider them, what would happen? Now you have to think that if your study is like lung cancer, and the persons are going to, the persons are going to die within a couple of months, in that case, if your study duration is study duration is 3 years, you can split the entire duration into 2 parts. One is the accrual period, another one is the follow-up period. So within the accrual period, whatever number of patients are going to come, you have to consider them, but don't allow to consider new patients while you entered in your follow-up period. So inter duration of 3 years need to be split with, let's say, for 2 years, first 2 years as the accrual period, and last 1 year as a follow-up period. So after 2 years, first 2 years, so beyond 2 years, first 2 years, you don't consider any patients, new patients, don't recruit any new patients. So that would be in the safer zones to consider the patients. Now, once within 2 years, whatever the patients are been recruited, so that patients may be recruited in the first month of your study durations or the last month of your study duration, but irrespective of these 2 years, after that also you are getting ample amount of time to get their follow-up or get them their death to be occurred. Unless and until death or event occur, you are not in a position to make the particular comparison. So after beyond 2 years, within a couple of, as I mentioned, we are talking about the lung cancer. So within a 3 to 4 months or 5 months or 6 months, you can expect all the patients will die. So in that sense, you can consider that the 1 year follow-up is good enough, so that your data would be in a very good shape of having most patients of the patients would be died, and they are basically, you are going to make the comparison between 2 arms or any therapy. So then the comparison will be having meaningful. But if your data is inflated with the more censored or alive persons, you are not going to make that particular comparison. So keep it in mind. So now, but it is a typical and good example if you work with the lung cancer or head and neck cancer to some extent. But if you talk about the breast cancer or the prostate cancer, where the event takes prolonged time, then you are not in a position and to make that comparisons and make that split and wind up your study. So you have to give the good amount of time to get that follow-up. So in that sense, I would say that few cancers are very easy to do the study because their relapse times and event time is quite narrow. But obviously there is a, because there is a provisions to improve the work. That's why maybe, and may say with the theoretically and fundamentally, God help us to do the store studies. So we can conduct those studies, but where you are having better survival, prolonged survival, so that studies takes lots and more efforts to conduct, because you can't expect more number of survival event in a particular time point. And while you don't get the number of events in a particular time point, making the comparison makes quite difficult over here. So that's the way. So this is a simple package. If you want to have some kind of how data should look like, there are not only these library SAAUR, there are sample packages are there, so you can apply those packages and you can see how these things works nicely. So this package would basically would give you how the data should look like in survival analysis. Another way that I already mentioned with this Excel file, stage, on-site, progressions, date of progression you can also calculate. Like I gave the date of last date of the follow-up, but the date of progression you can also put it over there. But if you take that date of progression, so similarly date of progressions minus on study need to be subtract, and then you will get the duration of progressions. And if you subtract from date to on study, then you are going to get duration of survival. So duration of progression and duration of survival, both you can calculate by duration of survival by this one by this one, and duration of progression by this one by this one. So these subtractions can be done, and obviously you are going to get that positive value. Sometimes what happens that you don't get the progressions of the patients. So you entered the study, the patient entered the study, patient died even, but still there is not any progression of the disease. Suddenly patient died. So what to do? So in that sense, if you are going to get that kind of data, the patients are interduration patient was there but no progression but suddenly died, that might happen. In that case, progressions you can't blank that value. Progressions date value you can't make blank. What you have to do, you have to substitute this blank value by last date of follow-up or date of death. So if it is a blank, put this value over here, and then you have to make the subtractions for these individuals, that sixth individual or fourth individual, like date of progressions minus on study. However, date of duration would come over there by subtracting from this value or this value, by subtracting this value from this value. And there is another important parameter that is should be there as a progression parameter. So while you are talking about the death parameter, so death status would be there, like died or alive. Similarly, progression status will also be there. And for progression status for particular patients, for these particular patients, you can put progression status as 0. Otherwise, those are having this progression status, it should be 1. Remember, every time this progression durations comes always earlier than the death duration. Obviously, death is a terminal event. Progressions always happen earlier than the death. And secondly, if these patients, you don't have the information, you can say the patients died without having progression. In that sense, you can put death of the patient as a progression date, and followed by you can put as a 1 or 0. So if the patients are, so patients was not progress, but patient died. So that kind of scenario might happen. Similarly, you can, once that, some software also work nicely, while rather than saying the date as a status, you can put the status variable. Now status variables can also be considered as a 0, 2, and 1. Sometimes what happens, you are in a dilemma that the patient was, for example, the patient was in lung cancer. The patients can't be alive more than 5 months. And you are not in a position to declare the patient is died or not, because you don't have the information of the patient. So commonly in retrospective study, this kind of scenario happen. So what we can do, rather than putting 0 and 1, if you put 0, then what would happen? It will show the patient is alive such a long period. That is one of the things. If you put 1, that you can put because you don't have the confirmation the patients are died or not. So what you can do? So that is a third category you can put, that you can put as a 2 over here. In another way, if the patients also died due to other causes, then also, if you know the patients died not due to the cancer, you know the patients are very good, but the patient's death was something else. So then you all can also put as a 2, and that makes sense to have that survival analysis work. So there are the data coding. It's very important to before applying or any analysis package or software. Now comes to that another terminology called hazard functions or survival functions. So survival functions, survival analysis method depend on the survival distribution, and two key ways of the specifying in are the survival function and hazard function. The survival functions define the probability of the survivals up to a time point t. So basically, while you are talking about the survival or death function, so basically you are talking about the S of t. S is nothing, the survival probability at time point t. So that is basically says up to time point t, how many were alive. That probability is mentioned by this probability terminology. So I will, once we go for the survival curve comparison, we will make more illustration on that, how to make it and how to say on that. The hazard functions, survival functions, both are similar, but one is vice versa of that. If a survival says that it is a 20% survival, so that's mean hazard function say it is a 80% hazard. So basically you have to subtract that from 1. So if a hazard function say 60% survival hazard, that's mean your survival is 40%. So again 1 minus 0.6 you have to subtract, then you will get 0.4. So these are basically addition of hazard value plus survival value, always supposed to be 1 or 100%. So the functions take the value between 1 to 0. So now thing is that it decreases or remain constant over time, and of course never drop below 0, because survival or hazard can be lesser than 0, and S defined is a right continuous. So and this, once the hazard is 1, that's mean all of them are died, so survival would be 0. And once the survival is 0, once the survival is 1, that means all of them are alive, then the hazard would be 0. So here hazard is 1, survival is 0, and survival is 1, hazard is 0. So that's the relation stand over there. So once is keep on decrease over the time, what happens? Survival go keep on decrease, and hazard keep on increase. So that's the way they cross each other. And while they cross each other, that term that 50% are alive and 50% are died, that duration is called the median survival time. And many times we are much more interested to work on the median duration of survival, and several studies conducted based on the median duration of survival. So 50% are alive and 50%, that's you are in a optimal value over here, but the both functions cross each other. So survival function is often defined in terms of the hazard function, which is instantaneous failure time. It is a probability that given time subject has survival up to time t, he or she fails in the next small interval of time divided by the length of the interval. So I can understand that the last line would be little difficult to understand, but once we go for the Kaplan-Meier or non-parametric approach to consider calculate, then it will be easier to understand. Formally, it is expressed as HT. Look, earlier I was talking about the ST, capital ST. Now I am talking about the HT here. And this is the similar way, alternative way of this representation of the survival functions. So once we are talking about the Cox-Ph function, Cox-Ph is nothing but the application of the proportionality hazard function. So then we are talking about the hazard functions. While you are talking about the Kaplan-Meier functions, then you talk about the survival functions. So both of them are used in same place, but their interpretation will be different. This function is also known as the intensity functions or the force of the mortality. The hazard and survival function, the two way to specifying the survival distributions. Objectives of survival analysis is basically estimate the time to event for a group of individuals, such as time until second heart attacks of a group of MI patients happen, to compare the time to event between two or more groups, such as treated versus placebo, MI patient in a randomized control trial, to assess the relationship of covariates to time to event, such as does weight, insulin resistance, or cholesterol influence survival time of the MI patient. Time to event between two groups using the t-test or linear regressions, because simple linear regressions or t-test can't be applied because one the time as a functions. So or the censoring mechanism even here, I would say. So that's why it's ignored the censoring, and simultaneously while you are talking about uh, event or make the odds ratio comparison just by applying the uh, logistic regression, they don't consider only this because the odds ratio in the survival analysis comparison, because that makes no sense, or don't go for t-test or linear regressions because that never consider the year. So time from entry into the study until the subject has been participated outcome. Censoring subject are said to be censored if there are lost to follow up or drop out of the study. Censored or they are counted alive or disease free for the time they are enrolled in the study. If the dropouts is related to both outcome and treatment, dropout may bias the result. So these are quite useful terminology in the survival analysis context. So that kind of methods I already mentioned over here. So these censoring mechanism. Now, as I say that hazard function and survival functions are both reverse to each other, and you have seen that survival functions looks the typically that you started with over there and it's dropped down, and hazard functions is started with low and goes up, but it's never happen always, means it is not always happen like this. So there are different way or different ways of the survival curves come, and for that there is a typical way of distribution testing and statistical testing and perform the hypothesis over there. So that's why this typical it is important, very much important to have the parametric statistical survival analysis approach over there. So then it would be in better positions to compare that curves and make the interpretations on that. So but here one kind of example is here, that hazard and survival functions. So we can expect that once the times keep on increase or days pass or year passes over there, so all the persons are going to die and their hazard is going to be accumulated, and this is going to be one standing with one. And simultaneously as age passes, irrespective of the gender, males, females, so their death is going to be more, so their survival probability is going to down. So this is the y-axis, survival probability. This is the y-axis, hazard probability. And as time passes with from 0 to 100, all of them are going to die, so their survival probability is going to drop. Whereas while they are having, as time pass, their accumulated hazard is going to be more, so they are going to be more death over there. So hazard is going to approach 1, and or cumulative, I would say cumulative hazard is going to approach 1, and survival probability is going to approach 0 over the time. This is the conventional and typical way to have the survival analysis, and this principle, this theory always applied any irrespective of the data you are applying, because whenever you are going to give the more number of days, more number of years of follow-up, event is bound to happen. Patient might not die due to the cancer, but obviously person is going to die. So event is going to happen. So it is bound to happen that the survival probability is going to be 0 after certain time. So that note I would end here. So if you are having any questions or comments, please let me know.